Good morning, good afternoon, good evening, everyone. We're just waiting 1 or 2 minutes for colleagues to join. We see people are joining, so bear with us as people log on. Thank you so much. Dr. Abdur, your hand is raised. If you have a question, can you pop it in the chat or the Q&A, please? You're currently unable to, the settings mean that the voice isn't on, but you can write in the chat or pop it in the Q&A. Thank you. Okay, welcome, ladies and gentlemen. Good morning, good afternoon, good evening. Thank you for joining us today with the Global Health Cluster. We are happy to be here after a lot of work. We are happy to launch our localization strategy with all our partners across the globe, and especially our health cluster partners who are working so tirelessly at country level. Just for you to know, my name is Iba Pasha. I am one of the technical officers from the Global Health Cluster. Today, we are joined by Jamil Abdo from the Tamdeen Youth Foundation from Yemen. He's also part of the NGO Forum in Yemen. We also have Dr. Mikias Abera from Fire Integrated Development Organization, FIDO, from the Ethiopia Health Cluster. He is also a Health Cluster Strategic Advisory Group member. Likewise, we have Mariam Abdel Karim Speakerman from the International Organization of Migration, and she is based in Dakar with the West Africa Hub. I have probably said that wrong. And lastly, but not least, with me from the GHC team, I have Francis and Virginie. And we will walk through with you to explain why we are launching the strategy, and the more important part, what the strategy is and how we can all advance this absolutely critical agenda. So, oh, I've gone the wrong way. Let me go backwards, perhaps. Right, I'm going to not see any of the participants, so help me if I go wrong. What is the cluster? I'm sure you're all aware, and I do not really need to say this, but just to make sure that we're all on the same page, the cluster approach is a global structure to help countries who are facing humanitarian crisis. The cluster is activated when national authorities need support in the coordination of humanitarian crisis. It does not happen unilaterally. It does not happen without them. There's a huge concerted process across all levels to the highest level within the UN to make sure this is activated and ensure that populations affected by crisis are receiving assistance. So at country level, what does that mean? It means partnerships, essentially, making sure we can be predictable and accountable and ensure that we're able to deliver humanitarian action. As you can see from this map, the cluster is activated in 29 settings and also 2 regional ones, which include the Pacific. What does this mean for overall structure is that we have the ISC, Interagency Standing Committee, which is chaired and convened by the UN Under-Secretary General for Humanitarian Affairs, the Emergency Relief Commissioner, and alongside heads of agencies and heads of NGO consortia, sit in the IESC and decide and guide our response. I am from the Global Health Cluster. We exist because of this mandate to ensure that correct support and appropriate support is happening at country level. And at national level, of course, many of you, I hope, many of you are from the national level and drive all the work that is being done to ensure populations receive appropriate humanitarian assistance. So just with the background with regards to localization, obviously everyone is very aware of it, and everyone is also very aware that we have not progressed as much as we should have. The concept came from 2016, the Grand Bargain. We have all made commitments at the global level, whether it's international NGOs or WHO and UN agencies, against this. And so for the Global Health Cluster, it is also within our strategy. The IESC has developed guidance in 2021 on how how clusters overall should be ensuring local partners are involved in leadership as well as the representation participation in the cluster forum. And so in line with that guidance, the Global Health Cluster has been able to drive this strategy. So over the past year, we have had a work plan around this, developing the strategy, and now we will be rolling it out. So after the development, we are excited to launch this strategy. Just as background, we had a very rigorous process with regards to developing this. We established a steering group which comprised of national NGOs from our health clusters, as well as some GHC partners. And together we developed a body of evidence regarding what goes well, what is going bad, with regards to ensuring local actors are participating in the health cluster. We did a survey, document review, and also case studies. And from this, we have had a consultative process to actually build this strategy. We've had drafts reviewed online, but also with focus group interviews with national actors and health cluster coordinators. And it has now been approved, and so we're very happy to share it with you now. So with regards for everyone to know where we are right now, and for them to hold us to account as we go forward, I just want to share some findings that we got from our baseline analysis within health clusters. So remember, we were thinking around leadership, that means coordination, co-coordination, as well as participation and representation. So just walking through some of these findings in the top left, you see the health clusters across the 29 settings coordinate with a lot of different partners, nearly 1,800 of them, and nearly 50% of them are national NGOs, 870 at a minimum that we know who are coordinating in health clusters. So that is quite a force and quite a big constituency of our health clusters. However, when it comes to leadership and co-coordination happens in 60% of our settings. So out of those 29, 60%. But none of these are co-coordinators from national NGOs, and we really want to change that and need to change that. Most of them are from INGOs, still not so many, and 4% are from Ministry of Health. Of the subnational hubs that we have, so not at the national level, but we have cluster coordination occurring subnationally, as I'm sure you're all aware. We have across the 29 settings, 120 hubs. Of those, actually, there is more leadership and co-coordination from local and national actors. 10% of them are co-coordinators from local and national actors, and that's similar to international NGOs. There's still a heavy representation of UN, so this is not WHO, and 41% from Ministry of Health. Going back to the national level, and the existence of strategic advisory groups, SAGs. SAGs do a variety of functions, for example, examining and discussing how the health clusters should be advancing strategically, discussing the challenges, the barriers that they are facing. But also they do things like vetting HRP projects or funding from humanitarian pool funds. So within our health clusters, 60% of health clusters have a SAG. And actually the representation of local actors is similar to international NGOs as well as the UN. As we can see there, about 25% are from those. Other members include observers as well as Ministry of Health or academic institutions. When it comes to technical working groups, and these tend to be situated at the national level also, we have many working groups across all our settings. We have 93. It can include topics such as sexual reproductive health, that's our most common, but also epidemic preparedness and response, also accountability to affected populations, health and WASH, many different types. And within that, actually, we see most of these are co-chaired by UN agencies. So 73% are co-chaired by UN agencies and 29% by INGOs. Local NGOs are not well represented within the leadership of technical working groups, and only 14% of technical working groups have a co-chair from an LNA. So on this note, I would like to hand over to Jamil, who will be walking us through a couple of the next slides. Over to you, Jamil.
Thank you very much. Just as Eva mentioned, that although has been some progress in mainstreaming locally led actions into humanitarian system, there is a challenge and barriers. Also, we have some enablers. In the barriers that one of the barriers that we face in localization is limited funding to local and national actors in terms of quantity and quality. There is no multi-year funding, no flexible funding. Also, there is limited access for local NGOs to certain funds. Also, political barriers, restriction impacting principled response. There is a politicization for the response or for the aid response. Like, for example, authorities can restrict access to certain population. Also, donors are restricted to not deal with certain group or certain de facto authorities, which is sometimes they are under sanctions. Also, all these criteria can impact and having impartial or natural humanitarian response. Inaccessible humanitarian coordination platform, like there is language barriers, physical access, also fitness for purpose. This means they don't have access to the coordination platform in other things. Lack of commitment and prioritization to localization. Although localization has been mentioned since since 2016, but we still have barriers in commitment for this commitment for the localization. For example, in local NGOs, they don't have access or they don't have enough funding to get or to be participated in the coordination platform. Also, there is the funding requirement. They require certain conditions, like to that local NGOs, they don't have access or they will not be able to access this fund. Also, there is no prioritization for when they nominating the coordinator at the coordinator or sub coordinator at the sub level. There is no prioritization for the local NGOs. Power imbalance in partnership and coordination platform. For the number of local, international and donors, international NGOs and donors in coordination platform are much larger than the local NGOs and the local actors, and they have limited access or limited power to affect the decision making on the coordination mechanism. Weak linkage existing between subnational, national, and global coordination platform. Yes, there is a miscommunication between the field level and the national level and also the global level the coordination mechanism. So, for example, people in terms of health cluster, people in there is some NGOs or local actors at the subnational level, they don't knew about the global health cluster. Next. Despite the barrier, but we still have some enablers that can improve the localization participation, like access. Local NGOs, they have access and their role very well recognized in security issues, in highly risky situation, or in access constraints challenges. But they still also available in the normal area. So they are existing. So they already existed. Increased momentum of localization. Yes, now we have to use or utilize the increased momentum of the localization, because now local NGOs, they are parting of humanitarian country team working groups, localization working groups, action plans at different levels, either global, nationally, or globally, and we have to utilize this momentum. Support from the authorities. Local NGOs, they have support from the authorities, and they really do have the support from the authorities, and they have good relationship with the authorities. So we need to get used of this in coordination platform. Country-based pool fund. The country-based pool fund now, there is a lot of progress in terms of localization. Like now, there is certain or certain reason for allocation only assigned to the local to local NGOs. So this also will enable utilizing the local and national actors in terms of in the coordination platform, and will help them to be more effective. I'm now give it to Francis to continue. Thank you.
Right. Thank you. Thanks so much, Iba and Jamil, for giving that wonderful overview and background to the localization strategy development process. We'll now switch gears to sort of unpack and walk through the different components of the strategy that I'll present, and followed by Virginia. Next slide, please. So first and foremost is, what is the purpose of this strategy? Well, this strategy, it's been designed to provide the health cluster coordinators, but also the health cluster partners, with that practical approach to mainstreaming localization, leading to meaningful, stronger engagement of the local actors. And as we'll see later on, the priority is not just on funding as one dimension on localization. We recognize it's important, and it's one that has dominated the discussions, but there are 6 or 7 other equally important dimensions of localization that we'll look at as we go through the rest of the priorities. Next slide. We thought it important to bring out our perspective in terms of how we define localization in the cluster, in the health cluster, recognizing that there is no single agreed definition out there, and that in many ways affects implementation, monitoring, and demonstrating the impact of which. For us in the health cluster, we don't want to get caught into the definitional debate, but focus on 2 aspects: that localization is a dynamic, continuously evolving, iterative process that should, at the end of the day, lead to meaningful engagement of the local actors. And we'll see what meaningful means in our context. Next slide, thank you. Before we go to the commitments, I wanted us to just take a look at the principles. And the principles we've outlined here are not new. These are principles, foundations for decision-making, for problem solving. It governs the way we conduct business in the humanitarian response, but also in the health cluster. And local actors, international actors, every stakeholder is to adhere to this. We won't go through all of them, but just maybe a few that frequently kept coming up. First and foremost is the issues around adherence to humanitarian principles. We won't go into the drivers, but we recognize that in different contexts, actors do face different challenges. The important point in this strategy is for us to recognize and support one another, work collectively for us to address those gaps such that we all adhere to these principles. The principles around equitable partnership is the foundation to our strategic priority number 2, where all actors in the health clusters, including local actors, we all engage as equal partners based on respect, mutual recognition of capacity, transparency, and being focused on nothing but results. On capacity sharing, I think that's the old foundation also of priority number 1, where as a cluster lead agency, our commitment to advancing localization is to have that open-minded approach to distribute and share our cluster leadership functions. Last but not least that I want to talk about is on the multidimensional nature of localization that I talked about, that in this strategy, we want to go beyond funding and look at localization in a very holistic sense. Next slide. We will now go through the different priorities that will lead us to this ambition, this dream, this vision that we have for a stronger engagement of local actors in the cluster. So let's look at the commitments that we see as, defining the different parameters of a meaningful engagement. Next slide. So what do we want to see across the board? First is that at the country level, we want to have an action plan, not just another white elephant heavy strategy document at country level, but really seeing an action-oriented action plan at the country level. And this is an opportunity where, as stakeholders, as partners in the health cluster, we can be part of that process. The second one is really to ensure that we, as you've seen from the baseline report, we want to increase the leadership sharing in the health cluster. So co-coordination at a national level from 0, I think, to at least 30%, and at a sub-national level, have that at 50%, because that's where the need is highest. That's where most of our local partners are situated. Decision-making in the structure and in the cluster. We've seen the SAG plays such an instrumental role in that decision-making, and we want to ensure that local actors are part of that process by expanding on the existence of SAG and the presentation of local members. The other component we will discuss as we go along different components of the strategy, but we want our partners to feel that their voices are heard, and we'll assess this through the CCPM that you give us your feedback at the end of every year. And finally, is around funding. We know it's important when we want to up our game and ensure that local actors do receive at least 40% of the funding that we have control on. So let's see then how we unpack or go through the different actions around these priorities. First is on leadership and accountability, that as a cluster lead agency, we will be open to sharing and distributing our leadership functions, predicated by the 3 principles around capacity strengthening, having clear milestones and accountability in that leadership engagement. So as already mentioned, we want to scale up co-coordination roles. And I just need to say one more thing here, is that in each and every context, the models that will be used will be varying. We may have only local actor, we may have a dual partnership with local international actors. Local actors are situated at a more decentralized subnational level, so we want to ensure also strong cluster representation and presence there. On that last is related to just the need for demonstrating the effectiveness of the progress, the impact of the actions that we will be taking to learn from these initiatives that we're doing. So strengthening monitoring and learning processes around localization is going to be part of the key priority for us going forward. The second priority, which in itself is also large, it captures a lot of the areas that we talked about, is just around representation and participation. And this goes beyond just coming for meetings, being present in the conversation table, but really as clusters, reinventing our themselves to ensure that everyone in the cluster, their voices are incorporated into the decision making, that their thoughts are publicly recognized. So around diversification, we want to reach out, capture as much as possible of the actors that we have, not just dominated by the usual, heavy culprits, but a larger representation. We want to see that everyone's action is publicly recognized, because that in a way also helps in shifting the narrative into a positive direction in terms of capacity and quality of work. It does not matter what you are doing, whether it's one activity, it's about what it means for the broader response. And we want to articulate that equitably. Lastly, is around strengthening the linkage between the different levels where the local actors are situated and engaging. We want to ensure that their voices, their perspectives, their opinion is reflected also at the national, at the global level, and vice versa. And we do have recommendations in terms of how we move that forward. With this, then I will turn it over to Mikia to share just a few reflections before we continue with the different parts of the strategy. Over to you, Mikia. Thank you.
Thank you, Francis. So the significance of this strategies in defining other dimension or areas of work to build on the work within the health clusters. It also opens new opportunities to think holistically about the locally led actions. It also clarifies the scope of work for partners to what needs to be achieved to accelerate the progress. So to share the experience as an organization, FIDO, we are a national NGO based in Ethiopia, and we are in the strategic advisory group for the national health clusters. Also, we are also represented in strategic review meeting, strategic review committee for reviewing proposal for country-based full funds. Also, as country, we do have also national NGO co-coordinating the sub-national level health cluster coordinations. So as an organization, also we are being part of the technical working groups at the national and sub-national, such as mental psychosocial support, surveillance technical working group, and others. So the strategies, this leadership commitment that create new opportunities to share the leadership is something local or national actors can do in co-facilitating the health cluster as well as the technical working groups. So this is an additional value that the strategy brings for the national NGOs. So for strategic priority 2, the cluster was at the sub-national and the national, give public recognition for the national NGOs for the work they are doing at their area. For example, the national gives recognition for the last mile delivery, where other actors like NGOs or other government cannot reach those areas, but the national NGOs are able to deliver in our context. So such types of actions is publicly recognized in the technical meetings, also in the health cluster meetings. So also the representation as country, we do have 7 sub-national health cluster coordination, but in order to increase this representation opportunities by reducing barrier is something the strategy is more working on, and it clarifies that. So this is something that the national NGOs, so locally led action, meaningfully can participate in the strategies, will allow us to show that the national NGO can contribute to that. Thank you. Over to you.
Great. Handing over to Virginie, I believe.
Thank you very much, Eba. So I'll walk you through very briefly the strategic priority tree, which combines with and for the local and the national actors, empowerment, resources in terms of access and control, and meaningful engagement. So here we want to note that funding is a critical enabler for LNA's engagement, and that health clusters have a role to facilitate this. We also want to highlight a couple of points, such as the importance to support the LNAs to play a more meaningful role in the humanitarian program cycle. And this includes notably supporting them with needs assessment when we're doing the humanitarian needs overview, and also giving them a more important role when it comes to formulating strategy and implementation plans, such as the humanitarian response plan. This helps indeed to align the project, but it also increases their likelihood of getting their projects funded. Definitely here, we also note the importance of transparency in resource distribution. And I think you're all familiar with the country-based pool fund. And the idea out here is to make sure that LNAs are included in project vetting and selection processes. And this is notably possible thanks to membership into the strategic advisory group or seminar committees by the LNAs. There's also an important point, and it has been mentioned already by colleagues, which is sharing and strengthening capacities for resource mobilization. This, we believe, would help the LNAs not only to join the humanitarian program cycle and so on and so forth, but also to develop strong business cases. There are various skills we can speak about, such as project management, reporting, evaluation, but also understanding of humanitarian principles. Definitely, as a global health cluster, and in this strategy, we strongly encourage other stakeholders to support the system and the governance improvements. And there, we're particularly highlighting the direct funding initiatives that are already existing. Finally, advocating with donors to support LNA is essential for the sustainability and the effectiveness of their engagement in health clusters. After this strategic priority tree, let us move to how this strategy is also focusing on the global health cluster strategic actions. There we have 3 pillars, 3 priorities. The first one is leadership, the second one is equitable representation, and the third one is access to resource. When we're talking about leadership, a couple of examples. We're talking here about how LNAs can play a more important role within the GHC, notably through membership in a task team or in the strategic advisory group. And we believe in there that it also means that we need to provide more technical support at country level to work with local and national actors so that they can engage with those mechanisms. The second point on equitable representation, we have various ideas in there. And the first one is indeed to have tools that are accessible in the local language, but also to have opportunities for in-person participation. This is really vital for inclusivity. There as well, we also refer to the visibility of local and national actors, both at country and global level. And we also want to bridge gaps in representation. Last but not least, access to resources. We've already mentioned it. This is essential, not only in terms of capacity sharing and skills building, but also in terms of investment for LNAs to manage coordination and project implementation effectively. So if we focus on leadership, equitable representation, and necessary resources, we're quite hopeful that at the global level and significantly, we can contribute to a meaningful engagement of local and national actors in the health cluster. I'll now hand over to Mariam from the IOM, who will share her views on how partners can support the strategy.
Thanks very much, Virginie. Good morning, good afternoon, good evening, everyone. Thank you for joining us on this exceptional launch of this localization within the global health cluster. Very briefly, what I want to share with you is the fact that this localization is important for all stakeholders and for 2 reasons within IOM. Within IOM, we have our internal localization already across all sectors within humanitarian setting. It's something that we have launched in 2022, and it's really been going on. And I'm super happy for the second point to link it now specifically focusing on health. And we recognize that international organization will hold the key to unlocking barriers. So how do we change our ways of work to support the realization of the strategy commitment? 2 points here. Minimum is increasing internal and institutional uptake by disseminating the strategy. when we go out of here. That's what we expect from everyone. Make sure that our relevant unit organization is aware and refer to the the global health cluster localization strategy in the cluster. I trust colleagues within IOM are ready for the change in coordination, of course, with the leadership in every location at the regional levels and at country offices. Within the area defined in the priority, leadership, representation, participation, and resourcing, the priority of IOM will not only be on one of the strategy, but it will go across. For an example, the visibility would go into highlighting the work of LNAs and facilitating linkages with donor. On the leadership part, support the LNAs, funding, co-coordinating perhaps for IOM-led technical working group, I would say, on the migration field. But within health, we stand ready to support the technical working group, LNAs as co-coordinators. And in this sense, when I talk about the specific point on two, diversifying the partnership, the role of IOM is to engage with the diaspora. And on that, I just wanted to mention one small reality from our actually localization framework. Diaspora are members of transnational communities and often have access to global perspective, knowledge, and experiences they can transfer to communities in their countries of origin, thereby opening alternative pathways to strengthen local effort and build local capacity and resilience during emergency, as well as in protracted crisis. They can help local organizations navigate the complex humanitarian system, connecting them to key actors and providing tools to sustained engagement and effective coordination. And I could go on and on and on, but within the time allocated, I think that's what I want to share with you at this particular stage. And I will give the floor to the next presenter. Over.
Thank you very much. Sorry.
You have 30
Yeah.
seconds for this, Virginie. Thank you. And then
And
we'll
it
go
will
to
be done
questions.
in 30 seconds. Thank you very much, Marianne. And hopefully we're all ready for the change you just mentioned. So let us just look very quickly in the way forward. So the strategy is now available on the GHC website in French and in English, and some other versions into Arabic and Spanish will soon be available. I want to focus here as well and inform you that very soon, hopefully your health cluster coordinators will reach out to you for some contextualization at the level of your different countries of operation. This will include localization action plans, localization workshop, but also some very practical tools for all of you, such as terms of reference, checklists that you'll be able to use to hopefully achieve this localization objective we all have. We're also going to work with a results monitoring framework, so you'll also have access to those data very soon. And finally, we invite you all to stay in touch with your health cluster coordinators to be updated about the next steps. And Eba, over to you. I'll hand over to you for the Q&A session.
Great. Thank you so much. I realize I gave you 30 seconds, whereas for partners, it's probably the most important. I think the message that we want to share with everyone is that we are coming to a health cluster near you. Please support the changes. Please help drive the changes. I hope we can all see some of the partners that we have joining right now. We hope to see them as co-coordinators, either at the national, sub-national, in the SAG or technical working groups within the next year. So on that note, I am going to try and stop this. We have 20 minutes, if needed. You may all want to leave, that's also fine. But really, please use the Q&A chat function or the chat box itself if you have any questions to ask. And if not, I have a couple of questions for probably Mikias and Dr. Jamil around this. I will let partners who are listening online pop anything into the chat. Or if you want to talk, you can also raise your hand. I see the allow to talk function has come up. So given we are 94 people, if anyone wants to come off mic, please do. But I think the main subject here is that we are really looking to drive change here. We have commitments that we have agreed on. It's within the highest level within the global health cluster that we were trying to achieve, and that will be with your head. So in the chat we have the strategy being disseminated. So we do have two questions, and maybe Francis and Virginie and myself, we can answer these. One is anonymous, but it says, how can we ensure localization efforts are actually contributing to achieving SDG 3, among others? Well, yeah, that's not just localization, that's health response in general. I think what we have learned, if you don't mind, Francis, I will put in my answer here, is that we are struggling to meet our SDG 3 targets. And if you talk to ministries of health, if you think about the World Health Assembly that just happened, we really recognize that a lot of the barriers are actually occurring in fragile and conflict and vulnerable settings. So if we are not able to deliver health services to the most vulnerable, there is really no way that we will be able to achieve SDG 3. And I think that's quite clearly recognized within WHO and across all ministries of health, and the concerted effort and emphasis that is needed. Again, the cluster system is a systematized approach. It is requested by national authorities. Our duty is to support national authorities in reaching the last mile. Health. How can we monitor how we are doing with regards to health? That, again, is the cluster approach. We need to be accountable for what we are doing. We need to demonstrate impact. And this is where the leverage of the health cluster is that we bring together everyone through your contributions, through your monitoring and reporting to us. We can demonstrate how many people we have reached or otherwise. So how much is it going to hit that target for SDG 3? It all depends on us and how much we are willing to move with that. We've got lots of questions actually, and we also have someone in the chat. So I think the chats came first and then a hand, and then I'll go back to the chat. So Francis and Jamil, maybe, how do you intend to achieve risk sharing with a local partner for project justification? And Jamil, Francis, over to you first, and then then either Jamil or Dr. Mikias, who I know also has experience in this.
Right. Thank you so much for that question around, how as a cluster we ensure risk management. I think the issue first to recognize is quite broad. But what we would like to bring to the attention of the cluster leadership and the partners is to So is that chat for me? Oh, sorry. Sorry. Yeah. So is to recognize that local actors, we capitalize on the notion that they have better access, they have operating hard-to-reach area in your areas, but that should come after a careful, meaningful evaluation of the benefits and the risks that partners will face, not just because we want to get the work done and they're willing to take the risk, but as stakeholders in the response, the strategy, what we're highlighting is that engagement, that decision needs to be after a careful risk assessment is done. And we have to commit to provide access to the tools, the resources that ensures that the local actors, when they're out in the field, they are able to put in place those risk management, risk mitigation measures. A very quick example, just before I hand over to Jamil to add on, is if in a conflict-ridden area, we want to send out a local actor, part of a good mitigation measure would be to have a national security officer or some physical, protection and all of this. But if that is not going to be captured in the budget framework as part of the overarching operational and support costs, then, and we're just focusing on program delivery, I think in terms of due diligence, we would have not done our part. And that's the kind of conversation that we try to emphasize in the strategy. Over to you, Jamil, if you want to.
Thank you. Jamil or Mikias, is there anything you would like to say that has been good practice with regards to risk sharing in project management from your side as a national NGO?
Thank you very much. Just to mention that the importance of giving the opportunity to the other actors to share their money. For example, as mentioned by Francis, that there is no ability, or the fund is not flexible for the local NGOs to be able to mitigate any risk or any risk. So we consider that risk sharing is really important during the program design and also the budget design, because if we didn't allow budgeting for any unforeseen risk or any risk management issues that can arise, that will be impossible for that. I'm not sure if I'm in the right track or I missed the question.
No, I think that's okay. I think we will, Mikias, if there's anything around risk sharing for the project, otherwise we will come on to the next questions. We're getting quite a lot, which I didn't expect, which is great. But Mikias, over to you, because I know it does come up a lot with regards to projects.
Thank you, Ipa. Just to share on our experience regarding risk sharing. So the most common risk is security. So most of the areas for the humanitarian crisis is security, and local NGOs are from the community, near the community. They know the contexts, and they use that as a way to go in and deliver their humanitarian assistances. So one thing it allows is risk versus benefits. So they know the benefit is the national NGOs to have the opportunities. It will also allow us to more capacity building partnership with NGOs, UN agencies. So these are the things as a benefit. For the risk, the security is a risk. So we have to analyze that with the cluster. So with this, more visibility, more opportunity, more capacity building will be offered at with the expense of giving this humanitarian assistance with this security tense situation. So the main thing is doing this risk analysis is always, and not to further push national NGO to do something that's not unreachable. So once we got the consensus and the capacity assessments to do that by the local NGOs, I think it will be beneficial for both NGOs, for the communities, as well as for the overall humanitarian communities. Thank you. Over to you.
Thank you, Dr. Mikias. Okay, we have a lot of questions and I'm trying to manage everything. But I'm going to condense them if that's okay to our participants. Nader, Fadul, thank you for your comments. You said regarding diaspora, that's a key part in building LNA capacity. So that was useful. I thought I saw a different question from you, but maybe not. Also, with regards to other comments we've had around how does the GHC plan to reach out to donors with regards to advocacy? They're perceived as high risk, there's fiduciary risk around it. How do we help that with securing funds? Francis, I'll come to you with that in a bit. There's also a second question of what is the definition of LNA, and I can respond to that in a bit. We had a comment that is it too narrow, just thinking about local and national actors. I presume we're also thinking about staff or government as well, that may be wider than that. Virginie, there's a question on the tools becoming available, and they will be. And there's a question around country-specific strategies being developed. Okay, I will just quickly say, with regards to local and national actors and the definition, for us, of course, within the health cluster, we support national authorities. And so ensuring that they are supported all the way down to the subnational level is one thing. But what's really become clear is our role in health clusters to support civil society. I urge everyone to look at the most recent WHO resolution on social participation, and it clearly articulates the role of civil society, local agencies, local NGOs are critical, as well as the community, being involved in health to ensure better health outcomes. So that resolution, it's available on the WHO website, and that was agreed across the board, across WHO member states. And it is a key part of universal health coverage. It is a key part of the primary healthcare approach. This is nothing new. Also within the IASC, it's very clear that we have a role as clusters to promote not just national authorities and support them, but promote and protect civil society. So while we have absolutely our obligation for national authorities and ensuring that we have capacities there, also for us, this strategy is specific for national NGOs, local NGOs, but it is replicable for ministries of health as well. Over to you, Francis, if that's okay, with regards to what that first question I had for you. The advocacy with regards to donors for the role, advocacy with donors for local NGOs. You've just
all right. Okay, thanks. I'll be really quick, and recognizing that we have a lot of details in the document itself. But just to emphasize a couple of things here, that advocacy is something we reference quite common and frequently, and yet we know that its impact is, it takes time. But what we want to do at the cluster level, I think, is to improve the quality of our advocacy by annexing that or attaching that to some clear results that demonstrate the efficiency, the impact of the work that we are doing with our local affairs. Hopefully that can, create that additional push, because I think one of the missing pieces here is the lack of evidence around demonstrating quantitative which. And I think the other bit, which is not just on the health cluster alone to push this advocacy to change these systemic issues, but it's around, a lot of discussions around risk appetite from the donors. I think it's something we can say, continue to say so, but the movement has to come from the collective. The third point, which perhaps I'll just emphasize, was mentioned in the previous discussion, is the role of the cluster as a convener. We do bring in different partners with different capacities. And in the strategy, we would like to see how can we use this convening opportunity to match existing strong group capacity to tailor to the needs of the local actors, hopefully work to strengthen the system, the governance that can help local actors comply or meet some of the requirements, building on the fact that in principle, the donors are also making efforts to come closer. Hopefully, as we do our part, we can, reach that meeting point much faster. I think that's what I can say.
Great. Thank you so much. So in essence, yes, we have a role to play in the advocacy, and we have launched this at the Global Health Cluster partner meeting where donors sit. We have this right now, and we will continue to do so. Virginie, I'd like to give you, there's a lot of questions in the Q&A, but 3 things. Number 1, a bit more of contextualization for countries. There's a question, will we have a strategy at country level? The other thing is around the M&E and the tools around that. And the second, number 3, is how do we build the capacities of local NGOs to do coordination? And so, as I say to everyone, it doesn't matter what agency you're from, everyone needs their capacity building with regards to coordination. So it's not a specific thing, but those 3 things as we go forward. Over to you, Virginie, please.
Thank you very much, Eba. So on the strategy, yes, there will be country action plans that will be developed collaboratively in each one of the country. This is why we were saying during the presentation, there will be localization workshops and then localization action plans that will be informed by those workshops. And in those workshops, we will work with the health cluster coordination teams to make sure that all stakeholders are being invited so that this is really an inclusive process for all local and national actors by 2025. So the strategy will be, yes, contextualized at country level through action plans. As for the monitoring and evaluation tools, so yes, they'll be shared at country level and they'll be used at country level and they'll be contextualized at country level. We're not aiming at saying that, for instance, a checklist on how do you work with local and national actors on this specific thing is the exact same thing in one context and in another context. So it's very important for us to work on contextualization. And indeed, this cannot be dissociated from the language. So as much as possible, we'll try to make sure that those tools are available in your local language so that you can use them as well and you can influence this process as well. When it comes to capacity sharing and strengthening, we insist on this sharing because we do believe that capacity is not only about, this we give you a training and you're going to implement. It's also about local and national actors who have capacities to share with the other stakeholders. So when it comes to this, we definitely want to disseminate the existing opportunities through the cluster because we've seen in many contexts that there are already lots of initiatives, but we also want to adapt some existing tools. Here, I'm going to give an example. At the Global Health Cluster, we're doing simulation exercises, SIMEX, and now we're working on adapting them for and with local and national actors, notably in their local language. Then just one small word on the other clusters. So definitely in countries where there are existing initiatives, we've been discussing with cluster where the humanitarian country team has a localization working group. We want to make sure that the localization action plans of the health cluster will be completely linked up with those other initiatives. Those can be civil society initiatives as well. So we really want to make sure we do not reinvent the wheel, we complement, and the health clusters are fulfilling those localization objectives. Back to you, Eba.
Great, thank you. I realize we only have 1 minute, colleagues, left, and I wish we had a 1.5 hours webinar or perhaps a workshop we should do next time for a Q&A session. But just to try this function, Jonas Kambale, vous êtes ici, vous avez levé tes mains, you have raised your hand. Is there anything you wish to comment on or ask, Jonas Kambale?
Muted. Well, thank you very much for this cluster, for this meeting. I really appreciate. I'm currently located in DRC, especially in Goma, and I appreciate this in fact. However, localization has not been much in some areas with different partners. And I think with this approach, we would like that you strengthen this this approach that international organization and the different UN agencies would help us to strengthen this relation and would really be of support so as the exit strategies be implemented fully. Thank you very much.
Jonas Kambale, thank you so much. You are 100% correct. I have nothing to add other than, okay, yes, we will. It is indeed part of our core functions of a health cluster or a cluster in general. Number one, to, well, there are many, but ensure advocacy, ensure that the cluster is functioning with regards to ensuring an exit strategy. So if we leave any cluster or coordination mechanism where it is not strong enough to continue without us, then we have not done our job. And so therefore supporting, ensuring those linkages exist between national, subnational, local authorities, as well as national, subnational, local partners, as well as the international organizations who are working in those areas or supporting projects in those areas. That is part of our work. So thank you for raising that, and we are trying. You can hold us accountable. We are accountable. Thank you. We are over, ladies and gentlemen. I feel very bad. We have 66 participants online. I will say we can close the meeting if you want to leave. That's okay. If people still have questions, Francis, Virginie, and I, we will be online right now to listen and try and respond. So I think if that's okay with colleagues online, I'm just asking, we can continue for another 10 minutes, but officially the meeting has finished, so you are free to go. But I will now ask Alex, as his hand is has been raised, if he would like to ask his question. Over to you, Alex.
It's quite encouraging to see how we have reached at this level. So your work is much appreciated, and especially in the area of localization. My take is I'm a little bit concerned when I compare with between this proposed strategy and how it will work versus see what is in the reality on the ground in the framework of difficulties and challenges in coordination, weak leadership, but also capacity and capability mechanisms are not already in place. There's a great mismatch between at a global level steering coordination, trickling down cascading at a national level. So my issue is, how do you build up a capacity that is sustainable enough to build community of practice of within the localization framework that is supported by the global actors? Because there is a great issue now in the humanitarian sector on how do we build that sector, but how do we build the ecosystem, but the humanitarian space. So when we are talking about localization in the health sector, we need to see how do we navigate between humanitarian health cluster, sector, ecosystem, and space and domain, and who is doing what and where. Because when it comes to mapping of different partners, actors, collaborators, and stakeholders, the issue is, after you have mapped them and you have assessed them, their capacity and their capability, and there's the resources that have been channeled to these institutions, organizations, be an NGO, CSOs, or whatever formulation is, and the model. My worry is, how do we sustain that model? There's an issue of project management. See, the problem that we're having in the humanitarian space and sector is we are in the project mode, and after the project finishes, then the entire system collapses. Yeah. So you have people that have been trained, you have the assets already have sufficient capacity. Then once the project finishes, what next? They cannot stand on their own. Then when we have an outbreak and a humanitarian crisis, we are starting all over again with another group. And the group that we started with the institution we have already dissipated, has disintegrated. So how do we maintain the database? How do we have a community of practice and networking that will continue to sustain, to keep the momentum?
Thank you, Alex. Alex, can you just let me know who you are working with and where you are based?
I'm based in Tanzania. I'm the managing director of Chigoto.
Oh, great. Does it work just in Tanzania, or sorry?
No, it's at a global stage, at a global level. I'm involved in different international humanitarian assistance, international development, but also international social change, research and innovation, also social impact investment and service delivery. So I'm in cross sectors, but also within the humanitarian sector. So that's why I'm concerned in a multi-country level. Yeah.
Yeah. Okay. Let's try and respond to this and some other questions. Briefly, I will say one-off is never enough. And even if you look at high-income countries and how civil society is supported, there's always turnover, there's always change. And slowly, of course, we grow to different levels of continuation. But I mean, I ask you to look at, I work with some charities in England, and we look at the turnover of charities or civil society organizations. So there's always new ones coming out and there's always other ones going. So turnover needs to be anticipated. Investment needs to be anticipated, and especially in a crisis, investment comes right at the beginning, and expect to be at ground zero. Now, the question is, how do we ensure the sustainability with one organization and ensure that's continuing? Absolutely. This is something that needs focus and more accountability or understanding amongst us to ensure that one organization doesn't fall apart, like you said, as soon as the funding finishes. Within the scope of the health cluster and our role, because we will not be able to have the answers for everything, I'm just going to hand over to Francis on really that age-old question is, how do we make sure that those changes or that capacity sharing or whatever it is sustainable beyond. Francis, I will give you 30 seconds if possible for that, and we still have some other questions if that's okay. Over.
Okay, the questions were longer than 30 seconds, but hey, listen, I think our response is the problems are multiple, but it's time that we start to nibble on them. We will not nibble on everything, but we will try our best to do what we can. Particularly, and just maybe to add on to what Ibe said, is you had raised the question of multiplicity, duplications, how we link what's happening in the other classes and other sectors. Well, it would please all of us to know that we do have the intercluster coordination function within the clusters. And the idea is to build on that linkage, to build on that platform as an information exchange, capacity exchange platform where we can all communicate and carry on the work that is happening from the different clusters as well. On leadership coordination, you mentioned about weak leadership, weak coordination. That's the essence of this strategy. And I won't repeat the actions that we have lined up there. Last but not least, Iber, I know I've gone beyond 30 seconds. It's just to say, if all these problems are true, if all these risks are true, then this is the more reason that we need to work with the local partners, because in the event that things are to disintegrate, at least we have the local rubric, we have the local fabric within which we can lean back and continue steering forward. Thank you. Over to you. I think you're muted, Iber. Sorry.
Well, of course I am. Someone has to be on mute and talk away in every single webinar or meeting. So I'm glad it was me. A quick question for Virginie, even though she's gone off camera. Can you just tell us about the other clusters that are doing similar things? That was a question. is this implemented across other clusters?
Yes, sure. So I'm not aiming here at providing an overview of what all the other clusters are doing, but Francis and myself have been particularly in touch with the UNICEF areas of responsibility related clusters, in particular the global nutrition cluster, but also some other clusters who've been putting together localization strategies, such as the global education cluster. And they have similar process of in-country checklists, in-country action plans that are very much focusing on the cluster in itself and its partners, and that do have those very user-friendly tools for partners. So if you are based in a specific country, it is possible that you're going to work on action plans of 2 different clusters. And this is why also we're referring about existing localization initiatives, because in many of those countries, and most of those countries we've been discussing with, there are some localization working groups that are inter-cluster or that are managed by different local and international NGOs. So definitely, yes, a lot is going on and is available on their website as well.
Great. Francis, I have a couple of questions for you. Number one is, oh, I've lost it. It's a very interesting one. Is supporting NGOs via funds and building their capacities, is this a good example of localization?
Repeat just one more time. Is
supporting NGOs via funding and building their capacity, is that a good example of localization?
It depends on what NGO we're talking about. If we're talking about an INGO, then that in many ways does not fit into the localization ambition. If it's a national or local NGO who, has the capacity or, the expertise to deliver on the task that at hand, I think the key issue parameter here is being clear on the responsibilities that we are tasking the partner to execute. And definitely if they need the resources to do the work, then I think the issue around here is that funding is the means. The end point is that we have a local partner doing the work. It may not be funding, it may be a collection of different other in-kind materials that is required to do the work. So yes.
Great. Okay, I think we are losing people now. So on that, I'm just having a quick little scan of the chat to see if things have been addressed or not. We've got diaspora, we've talked about this and focus on participation. I think we can bring it to a close. Right, so on that note, thank you very much, partners who have stayed on. Thank you for those who have asked. I don't think there's any other hands up. I think we've addressed most of the questions. We'd just like to wrap up saying, number one, yes, this is ambitious, but number two, it's happening. All clusters, as Virginie have said, have a strategy around this. IESC have been clear. We have learned from COVID. We have learned from many situations that, especially conflict or access constrained areas, as Jamil has said, that this is when we recognize the importance of local actors, but local actors are there no matter what. So our role as the cluster is to ensure, to do our active outreach, to bring in those who are contributing to better health outcomes for populations affected by crisis, to bring that linkage in, ensure that we're engaging with those with national authorities, and also ensure that feedback upwards. Every context is different, we know that, but we are committed, and we will be coming to every health cluster with regards to this. So if you are part of a health clustering country, expect a visit from Virginie or myself, or maybe even Francis, to take this forward. Each country will look different, each context will look different depending on what it is. what those challenges are or otherwise, but we are committed to this. So please think about what that means for you. Think about how, number one, you can support it. Do you want to be a co-coordinator? Is this something you are able to do? Is this something you are not able to do? If it is something you think you're able to do, what do you need to do it? As has been highlighted by many of the people who have popped in questions or asked, how do we make this happen and how can we make it more sustainable? So this is how we will be working on it for the next year and a half at minimum. But we look forward to your collaboration, your direction. The Global Health Cluster and Health Cluster, we do not lead, we do not tell people, we listen, and then together we formulate that strategy, and together we formulate possible solutions. So hopefully together we can go forward and really try and have locally led action that is appropriate and meaningful for populations affected by crisis. So on that note, I'd like to say thank you very much. Thank you very much to everyone who joined. And feel free to reach out to us, healthcluster@who.int, if you want any follow-up. Thank you so much. Good evening, everyone. Good afternoon and good morning.